Imagine you have this incredibly lush, thriving garden. The soil is rich, the plants are resilient, and everything is kept perfectly in balance by a reliable automated sprinkler system. But then a crisis hits. You discover that the very water keeping that garden alive is somehow feeding a destructive weed that threatens to take down the entire property.
So to save the house, you basically have to turn off the water
Mhm.
completely. I mean, it's an essential survival mechanism, but the collateral damage to the rest of the landscape is immediate.
Right, exactly. The garden dries out, the soil cracks, the plants wither, and the entire ecosystem just becomes incredibly fragile. And traditional advice says, whatever you do, do not turn that water back on. So what happens to the soil? Today, for this new deep dive, we are looking at a massive, controversial medical dilemma surrounding a highly specific and frankly rapidly evolving intersection of oncology, gynecology, and laser technology. We are talking about transvaginal laser therapy for chemotherapy-related vaginal atrophy, which is clinically known as genitourinary syndrome of menopause, or GSM.
Yeah, and we have synthesized a massive stack of sources for you today. We are pulling clinical guidance from NICE, the National Institute for Health and Care Excellence, along with guidelines from the British Society of Sexual Medicine. We're also examining randomized controlled trials, like the Velvet and Light trials, and contrasting that robust clinical data directly against the very enthusiastic marketing materials from laser clinics offering treatments like the Mona Lisa Touch and FemTouch.
Right, because our mission today is to help you cut through the noise. We want to understand the exact biological mechanisms of these lasers. We need to weigh the fiercely conflicting evidence between those clinic claims and the extremely cautious regulatory guidelines. And most importantly, we want to figure out what this all means for the millions of breast cancer survivors who desperately need non-hormonal relief. You might be wondering why we're looking at lasers in gynecology. Well, for these survivors, this technology is sitting right at the center of a massive battle between cutting-edge pain relief and strict regulatory caution.
And to really grasp why this debate is so fierce, we have to look at the biological reality these patients are enduring. I mean, up to 70% of breast cancer survivors develop severe genitourinary syndrome of menopause. This is not just mild discomfort we're talking about here.
No, definitely not.
We are talking about chronic vaginal dryness, intense burning, itching, and dyspareunia, which is the clinical term for intercourse that is so painful it essentially becomes impossible.
I want to understand why this happens so frequently to this specific group. If a patient goes through chemotherapy or takes adjuvant treatments, I saw aromatase inhibitors mentioned constantly in the sources, for example. How does that trigger such an extreme localized reaction?
Well, those treatments are designed to systematically drain estrogen from the body, because estrogen is what was feeding their specific type of cancer. Estrogen is essentially the water in our garden metaphor.
Yeah.
It is biologically crucial for maintaining the vagina's elasticity, its hydration, and a healthy acidic pH. It promotes the growth of lactobacilli, the good bacteria that ward off infections. When you introduce an aromatase inhibitor, you aren't just lowering estrogen, you are virtually eliminating it.
Wow.
The vaginal tissue literally thins out. It loses its natural folds, the blood supply diminishes, and it becomes easily inflamed and, frankly, highly susceptible to microtears.
Normally, for women going through natural menopause, doctors might just prescribe hormone replacement therapy or a localized estrogen cream to soothe those symptoms. But for a breast cancer survivor, traditional medicine seems completely unwilling to turn that sprinkler system back on.
There is a profound systemic fear of using any estrogen in these patients. Oncologists and patients alike worry that introducing even local topical estrogen might trigger a recurrence of the cancer. Interestingly, though, the British Society of Sexual Medicine notes that this fear might be slightly overstated in certain contexts.
Oh, really?
Yeah, they point out that after the vaginal skin cornifies, which just means the outer layer of skin cells toughens up and creates a sort of keratinized barrier, local estrogen doesn't significantly raise systemic estrogen levels past normal postmenopausal ranges.
So medically speaking, it might actually be a small, acceptable risk for a fully informed patient to use an estrogen cream. But the fear of litigation from doctors, coupled with the absolute psychological terror of the cancer returning for the patient, just leaves this massive void in care.
Exactly, which leaves women relying on non-hormonal moisturizers, like hyaluronic acid. But the clinical literature shows those require really heavy, frequent use, like applying them 3 to 5 times a week, just to maintain basic comfort. For many women with severe tissue atrophy, those over-the-counter moisturizers simply fall short of providing real relief.
Right, so if the medical community is terrified to provide hormonal therapy and the non-hormonal creams aren't cutting it, it makes total sense that energy-based devices are rushing in to fill the void. But the way they actually claim to work is where I started getting confused rooting the sources. How does shining a laser inside the body actually treat severe tissue atrophy?
Well, the research details two primary categories of lasers being utilized. The first, and definitely the most widely discussed, are the ablative lasers, which includes fractional CO2 and erbium YAG lasers. These devices emit electromagnetic energy that is highly absorbed by water.
Wait, hold on. They absorb water. You just explained that this tissue is essentially a desert. It's completely thinned out and dry. How can a laser target water in tissue that basically has none?
It's a great question. Even in severely atrophic tissue, there is residual intracellular water trapped inside the cells themselves. When the laser's energy hits that microscopic amount of water, it instantly vaporizes it. This creates an intentional microscopic thermal injury in the vaginal epithelium. The laser is literally physically damaging the tissue on purpose.
See, here's where it gets incredibly counterintuitive. We're putting a laser inside the body of a woman who just survived grueling, cellularly destructive chemotherapy to cause intentional injury. Isn't cellular damage exactly what she wants to avoid at all costs? It sounds like we are conducting controlled burns in a forest just to stimulate new growth.
What's fascinating here is that the controlled burn analogy is incredibly apt.
Oh, really?
Yeah. The key difference is macro injury versus micro-targeted remodeling. If you were to burn the entire surface of the tissue, that would be a destructive macro injury resulting in horrific scarring. But these lasers are fractional. They create tiny, separated columns of thermal damage, leaving healthy tissue intact all around the microscopic wounds.
So the body senses these tiny injuries and rushes in to fix them, and in the process, it repairs the surrounding area that it had basically abandoned.
That is the exact mechanism. This micro-injury triggers the body's natural wound healing cascade. It wakes up the fibroblasts, which are the cells responsible for building our structural framework. The fibroblasts start producing brand new collagen, a process called neocollagenesis.
Right.
The healing cascade also stimulates neovascularization, which is the formation of new blood vessels. Over several weeks, the tissue naturally thickens, elasticity returns, and as blood flow increases, the tissue begins to naturally produce glycogen and lactobacilli again. Dermatologists have used this exact same fractional collagen rebuilding concept for decades on the face to treat wrinkles. They just took that cosmetic technology and adapted it for the vaginal mucosa.
Okay, I get the controlled burn idea, but my sources mention a second category, non-ablative lasers, specifically near-infrared ones, and those don't burn anything at all. If you aren't causing that microinjury, how are you tricking the body into healing?
Non-ablative lasers operate entirely differently. They utilize a process called photobiomodulation. Instead of heat and vaporization, the photons from the near-infrared light penetrate deep into the tissue and interact directly with a very specific receptor inside the cell's mitochondria. It's a chromophore called cytochrome sp oxidase.
It sounds like a biological solar panel. You're taking light and somehow converting it directly into functional cellular energy without the destructive step.
The solar panel comparison is functionally perfect. Cytochrome sp oxidase is highly sensitive to certain wavelengths of light. When the photons hit that receptor, it causes the mitochondria to release nitric oxide.
And what does that do?
Nitric oxide is a powerful vasodilator, meaning it rapidly opens up blood vessels and relaxes smooth muscle tissue. Simultaneously, this light absorption ramps up the cell's production of ATP, the fundamental energy currency of the cell. So you are essentially increasing blood flow, reducing pain, and modulating inflammatory pathways on a purely biochemical level without vaporizing a single cell.
So we have two radically different technologies trying to solve the same biological drought. One uses controlled microscopic damage to force a repair response, and the other acts like a solar panel to stimulate cellular energy and blood flow. Both of those mechanisms sound incredibly elegant in theory. But when we look at the clinical reality, we run into a severe collision between what the clinics are promising and what the regulators are allowing.
The disconnect is jarring. I mean, if you look at the marketing materials for devices like the Mona Lisa Touch or the Fem Touch, the observational studies in case series report overwhelming successes. We are seeing 80 to 90% patient satisfaction rates.
Yeah, they cite massive drops in visual analog pain scores and vastly improved vaginal health index scores. What exactly goes into that vaginal health index anyway? Because the marketing brochures treat it like an absolute objective truth.
Right, so the Vaginal Health Index, or VHI, is a clinical scoring system that assesses 5 parameters: elasticity, fluid volume, pH level, epithelial integrity, and moisture. In these clinic-backed observational studies, after just 3 5-minute laser sessions spaced a few weeks apart, women's VHI scores consistently skyrocket. Many report life-changing relief, a return to comfortable intimacy, and just a drastic improvement in their overall quality of life.
But then you flip the page to the guidance from regulatory bodies, and it's a completely different story. The 2021 NICE-E guidelines, which they firmly reiterated in their 2024 Menopause update, explicitly state there is inadequate evidence on long-term safety and efficacy. They recommend this procedure should only be used in the context of formal research, and the US FDA issued a very aggressive safety communication warning against the use of energy-based devices for what they called vaginal rejuvenation.
Exactly. The FDA explicitly warned of potential severe adverse events, including burns, scarring, and persistent chronic pain resulting from these lasers.
So, why the massive disconnect? We have clinics saying it's a 5-minute miracle that gives cancer survivors their lives back, but regulators are slamming on the brakes. Are the regulators just being bureaucratic killjoys who don't understand the plight of these women, or is the clinic marketing running completely away from the actual science?
This raises an important question about the hierarchy of medical evidence. We have to scrutinize how those glowing clinic numbers were generated. The vast majority of the highly positive data comes from observational studies or case series. In an observational study, the patient knows they are receiving the high-tech laser treatment. Furthermore, because these treatments are almost never covered by insurance, these women are paying thousands of dollars completely out of pocket.
Oh, wow. When you hand over $3,000 for a cutting-edge laser treatment, your brain really, really wants it to work.
The psychological and financial investment is massive. Regulators understand that this environment creates a perfect storm for the placebo effect. That is why bodies like NICE and the FDA do not accept observational case series as definitive proof. To prove a medical device actually works because of its physical mechanism, and not just because the patient believes it will work, regulators demand randomized controlled trials RCTs, where the treatment is compared against a gold standard medication, or even a fake sham treatment.
Okay, so let's dig into those highest tier randomized controlled trials. The sources highlighted the Velvet trial, which compared the fractional CO2 laser directly against the gold standard, which is vaginal estrogen cream.
Right. The Velvet trial was considered a landmark study at the time. They randomized 69 women into 2 groups. After 6 months, both groups showed significant, meaningful improvements in their symptoms. The group that received the laser and the group that used the estrogen cream had virtually identical reductions in vaginal dryness and dyspareunia.
Wait, on the surface, that sounds like a massive victory for the laser. If it's performing equally to estrogen cream, but completely avoids the cancer recurrence risks associated with hormones, why didn't that trial make it the global standard of care?
Because comparing a new device to an existing treatment doesn't rule out the placebo effect of the device itself. To truly isolate the laser's physical efficacy, to prove that the controlled burn or the photobiomodulation is what's actually curing the pain you have, to compare it against a fake laser.
Which brings us to the LIGHT trial, published by Lai and colleagues in the Journal of the American Medical Association, JAMA, in 2021. This was a double-blind, sham-controlled trial.
Yeah, and this specific study is the cornerstone of the current regulatory caution. The LIGHT trial took 88 patients. Half of the women received the real fractional CO2 laser treatment. The other half had the exact same probe inserted, they heard the identical machine noises, the doctor went through the exact same motions, but the laser energy itself was turned off. It was a complete sham.
If you're listening to this and thinking, wait, a fake laser cured their pain, you aren't alone. This is what broke the medical consensus. What were the results at the end of the year?
At the 12-month mark, the researchers found absolutely no significant difference in symptom severity between the women who received the actual laser and the women who received the sham treatment. Both groups saw some improvement in their symptoms, but the real laser did not statistically outperform the placebo.
That is a devastating blow to the clinic narratives. If the fake laser works just as well as the real laser, it implies that the elaborate biological remodeling we discussed in neocollagenesis, the solar panel effect might not be the primary driver of the symptom relief.
It definitely forces the medical community to ask how much of the reported release is strictly biomechanical versus how much is tied to the placebo effect or just the natural fluctuation of the condition. And honestly, the placebo effect in device and pain trials is a fascinating biological phenomenon. It isn't just a statistical anomaly, it is a genuine neurochemical response.
How does that actually work? Because we aren't talking about mild headaches here. We are talking about women with such severe tissue atrophy that physical intimacy is physically impossible. How can a fake laser fix that?
When a patient is desperate for a cure and they undergo a highly ritualized medical procedure involving advanced technology and significant financial investment, the brain's descending pain modulatory system activates. The brain actually releases endogenous opioids, the body's natural painkillers, and alters the way it processes nerve signals from the pelvic region.
That's incredible.
It is. The subjective experience of pain genuinely decreases because the brain firmly believes an intervention has occurred. Combine that with the cognitive dissonance of having paid out of pocket, where the patient unconsciously downplays their lingering symptoms because they don't want to feel they've wasted their money, and you get incredibly muddy clinical data.
So, when your highest quality double-blind trials show no difference from a placebo, it makes complete sense why NICE guidelines state the evidence is inadequate. The medical establishment simply cannot endorse a treatment if they can't prove the machine is doing the actual work.
Right. But we also have to examine the safety aspect of the FDA's warning, because researchers in our sources push back aggressively on how the FDA framed this issue. The FDA grouped medical treatments for severe genitourinary syndrome of menopause under the broad, colloquial umbrella term of vaginal rejuvenation.
Yeah, researchers like Guo and colleagues argue that this was a deeply flawed, almost irresponsible conflation. Vaginal rejuvenation is widely used to describe elective cosmetic procedures, things like vaginal bleaching or tightening, requested for purely aesthetic reasons by healthy individuals.
Exactly. By lumping a critical, debilitating side effect of cancer treatment in with cosmetic touch-ups, the FDA painted the devices with a remarkably broad brush of risk. Guo and colleagues actually went back and reviewed the FDA's MAD database, which tracks real-world adverse events for all medical devices.
And what did they find?
Out of hundreds of thousands of transvaginal laser procedures performed globally, they found exceedingly few severe adverse events. The catastrophic burns and scarring the FDA warned about were statistically incredibly rare. The vast majority of complaints were temporary spotting, mild transient pain, or simply a lack of efficacy.
That feels incredibly unfair to the patients. It's like banning all scalpels just because you don't like a specific plastic surgery trend. You're taking a potential tool away from a cancer survivor in agonizing pain because someone else is using a similar tool for cosmetic reasons. The risk profile is actually quite low when performed by a medical professional for a legitimate condition.
The risk-benefit calculus for a breast cancer survivor who is completely unable to experience intimacy or go about her daily life without chronic pain is vastly different from someone seeking an elective cosmetic change. These women are caught in a brutal medical no-man's land. Hormones are considered too dangerous by their oncologists, the non-hormonal creams don't work, and the lasers are trapped behind a wall of regulatory skepticism driven by the placebo effect.
It perfectly illustrates the desperate need for independently funded, large-scale, sham-controlled trials that aren't just bankrolled by the laser manufacturers themselves. Right now, patients are left relying on glossy marketing brochures instead of definitive medical consensus.
Bringing this all together, transvaginal lasers represent a fascinating non-hormonal frontier. The technology relies on solid biological theories, whether it's the microthermal injury of ablative lasers stimulating collagen or the photobiomodulation of non-ablative lasers increasing cellular energy.
But for you, the listener, this deep dive reveals a classic medical paradigm. Innovation almost always sprints years ahead of the slow, methodical, necessary pace of regulatory science. We know tens of thousands of women report life-altering relief, but the overwhelming presence of the placebo effect in trials like LIGHT means regulators have to enforce a frustrating level of caution.
Which leaves us with a lingering, almost philosophical question that really challenges how we define successful medicine.
Yeah, think back to our drought-stricken garden. The soil is cracking, the sprinklers are permanently off, and nothing is growing. If a treatment's physical efficacy is ultimately proven by future trials to be heavily reliant on the placebo effect, meaning the high-tech laser itself did very little biologically, but the ritual of the treatment still successfully provides life-altering pain relief to a cancer survivor who has absolutely no other safe medical options, does the actual mechanism of the relief really matter? Should we care how the garden came back to life, as long as she gets her quality of life back?
It's a profound question about the intersection of human psychology, pain perception, and the lengths we will go to for healing.
Definitely something for you to mull over. We'll catch you on the next deep dive.